Ever wondered about the incredible biological story that unfolds within us? That intricate dance of hormones and development that shapes who we are? Or maybe what happens when that complex choreography hits a snag? Today, we're taking a deep dive into one of the most fundamental and I think really fascinating aspects of human biology, their reproductive systems.
Yeah, absolutely fascinating. And our mission for this deep dive is to, well, truly demystify the structure, the function, and the common alterations of both male and female reproductive systems. Think of us as your personal guides through a comprehensive unit from Understanding Pathophysiology, the 7th edition by Huther, McCants, Brashers, and Rocher. We're basically here to give you a clear, accessible understanding, really connecting the dots between how these systems are supposed to work and what happens when things, veer off course. We'll journey from those very early embryonic beginnings all the way through to the effects of aging and various disorders, making sure to highlight how each piece of this biological puzzle connects.
That's right. We really want you to come away with those aha moments, feeling like you truly grasp the central themes, not just like a list of facts. And as we go, where the text refers to complex diagrams or maybe figures, we'll try and paint that picture for you in words so you can sort of visualize these amazing processes as we talk. Okay, let's unpack this by starting with the very foundations of the reproductive systems. We're drawing from chapter 34 here. So at its core, what unites both male and female systems is their primary mission: reproduction. It's this astonishing process that begins with the union of a female gamete, that's an ovum, right, carrying 23 chromosomes to clone zygote, and a male gamete, the spermatozoon, also with 23 chromosomes. Together, they form a 46-chromosome zygote, the very first cell of a new individual. So, well, it's truly a remarkable start to life.
It really is.
Yeah.
And what's truly fascinating here is that reproduction isn't just about the physical structures.
Yeah.
These intricate functions are choreographed by, well, unbelievably complex hormonal and neurological factors. So while the male system is engineered to produce and deliver sperm, the female sister is designed to produce the ovum and then, if fertilization occurs, to nourish and protect that developing embryo and fetus.
Yeah.
It's a precise, highly coordinated biological ballet, you could say, each system with its specialized role.
Right, a ballet. I like that. And the entire performance, it seems, hinges on a specific class of chemical messengers, steroid hormones like estrogen and testosterone and their precursors. And here's something that might surprise you. Cholesterol is a foundational building block for all of these steroid hormones. So yeah, even cholesterol plays a role in reproduction. But it's not just steroids. Other non-steroid hormones, which we broadly call gonadotropins, are also absolutely crucial for this system to function.
Exactly. And like all hormones, these sex and reproductive hormones exert their effects by binding to specific cellular receptors on their target tissues. That's how they work. What's truly remarkable is that their influence begins incredibly early during embryonic development and continues, though maybe in varying degrees, throughout your entire life. They orchestrate pretty much everything from libido and cognitive functions like learning and memory to more visible changes like muscle and bone growth and even sebaceous gland activity, which as many of us remember, can lead to acne during puberty.
Okay, so if these hormones are such powerful players, how is their action actually coordinated? This brings us to a critical communication network, a feedback loop, essentially, known as the hypothalamic pituitary gonadal axis, or HPG axis for short. Think of this as kind of the central command center for reproduction, involving 3 key players. The hypothalamus in your brain, the anterior pituitary gland, that small gland just below the brain, and the gonads, which are the ovaries in females or the testes in males.
You can visualize this like a 3-tiered control system, a classic feedback loop. At the very top, the hypothalamus acts like the master thermostat. It releases GnRH, that's gonadotropin-releasing hormone. This GnRH travels just a short distance to the anterior pituitary gland, which then acts as a relay station. The anterior pituitary responds by releasing 2 crucial gonadotropins, FSH, follicle-stimulating hormone, and LH, luteinizing hormone. These are the direct messengers that travel through the bloodstream to act on the gonads, the ovaries, or testes. The gonads, in turn, respond by producing the sex hormones, estrogen, progesterone, and testosterone. And here's where the feedback part comes in. These sex hormones then circulate back to influence the hypothalamus and pituitary, basically telling them whether to ramp up or dial down their activity. This HPG axis isn't just some abstract concept. It'll be a recurring theme as we explore both normal function and, what happens when things go awry.
Okay, having understood that master control system, let's now journey back to the very beginning, the incredible process of development. The first hints of reproductive organ formation, whether male or female, appear remarkably early, around the 5th week of gestation. Just a tiny primitive structure, but it holds enormous potential.
hmm And this raises a really important question. What's the switch? What determines if this indifferent structure becomes male or female? The crucial moment for male differentiation happens between 6 and 7 weeks gestation. This pivotal decision is driven by a specific gene called the SRY gene. That's the sex-determining region on the Y chromosome. When this gene is expressed, it produces a protein known as test-determining factor, or TDF. You could almost imagine a diagram showing that initially indifferent gonad and then the SRY gene acting like a toggle switch. If SRY is present and active, bam, male gonadal development takes over. So if that SRY switch is flipped, TDF stimulates the gonads to become testes. And by just 8 weeks, testosterone secretion begins. Pretty amazing. At the same time, specialized supporting cells within these developing tests, called Sertoli cells, secrete another crucial hormone, Müllerian inhibitory hormone, MIH. This MIH acts like a biological stop sign, causing the degeneration of the Müllerian ducts, which would otherwise form the female internal genitalia like the uterus and fallopian tubes. Meanwhile, other cells, called Leydig cells, also within the testes, produce testosterone. This testosterone then promotes the development of different structures, the Wolffian ducts, into key male reproductive organs like the epididymis, vas deferens, seminal vesicles, and ejaculatory ducts. And then by around 9 months of gestation, the testes complete their journey, descending to the scrotum.
So in the absence of that SRY gene, if there's no Y chromosome, or maybe if the SRY gene isn't expressed, the default pathway just naturally leads to female gonadal development. And what's a critical difference here is that the production of primitive female gametes, or ova, occurs only during fetal life. You're basically born with your lifetime supply. That's a key contrast to males, right? Who will begin producing sperm at puberty and continue doing so throughout most of their lives.
Precisely. While a female fetus does have high levels of FSH and LH, stimulating some estrogen and progesterone production, these levels decline significantly before birth. After that, from puberty all the way to menopause, typically only one ovum will mature and be released each menstrual cycle. Just one. And if we connect this back to our HPG axis, the anterior pituitary gland develops quite early in fetal life, and its direct vascular connection to the hypothalamus is established by week 12. And GnRH, that master regulator hormone, is already produced by 10 weeks gestation, controlling LH and FSH production. It's basically setting the stage for all future reproductive function.
Now, let's fast forward to a truly transformative period in human development, puberty. And it's important, I think, to differentiate this from adolescence. Adolescence is that broader stage, encompassing social, psychological, and biological changes, a time of profound growth and identity formation. Puberty, however, is specifically the biological onset of sexual maturation, the point when you become capable of reproduction.
Right, and the timing of when puberty actually kicks in for any individual is influenced by a really complex interplay of factors. Genetics, your environment, your ethnicity, your general health, and importantly, your nutrition. For example, studies have shown that increased weight and body mass index can sometimes lead to earlier puberty in males, which is a fascinating insight into how environment impacts development.
And speaking of timing, there are general milestones, aren't there? In females, puberty usually begins around 8 to 9 years old with the larch, which is the initial development of the breasts. For males, it tends to start a bit later, usually around 11 years, though this can definitely vary.
And here's where the HPG axis, our master command center, gets really interesting again. About a year before the visible outward signs of puberty even begin, that HPG axis kicks into high gear. This means there's a significant increase in the production and secretion of GnRH, which then stimulates the anterior pituitary to pump out more FSH and LH. These crucial gonadotropins, in turn, stimulate the gonads, the ovaries or testes, to secrete their respective sex hormones. This entire hormonal cascade leads to the maturation of the reproductive organs and, in females, breast development. Puberty is considered biologically complete with the first ovulatory menstrual period in females, signifying the capacity for conception.
And the first ejaculation containing mature sperm in males, yeah. So that's the biological endpoint, basically.
Exactly. That's the biological marker we look for. You can almost visualize this entire process as a dramatic awakening of that positive feedback loop we talked about. The hypothalamus stimulates the pituitary, which stimulates the gonads, and then the gonadal hormones feed back to influence the hypothalamus and pituitary, amplifying the signal until full maturation is achieved. It's quite a process.
Okay, moving on to the intricate specifics of the female reproductive system. Its overall function is truly profound, producing mature ova and, if fertilization happens, protecting and nourishing the fetus all the way until birth. It's a system just exquisitely designed not just for creating life, but for sustaining it.
Absolutely. Let's highlight some key internal anatomical players. The vagina, for instance, is a muscular canal. Its self-cleansing action is critically maintained by an acidic pH, typically between 4.0 and 5.0 during the reproductive years. This acidity, along with the thick epithelial lining, is heavily influenced by high estrogen levels and the presence of Lactobacillus acidophilus, a beneficial resident bacterium. And here's a key clinical insight. Before puberty and after menopause, when estrogen levels are lower, the pH becomes more alkaline and the epithelium thins, which unfortunately increases the risk of infection. Makes sense, right?
Yeah, that does make sense.
Okay, next up, the uterus. This pear-shaped muscular organ is composed of 3 distinct layers. You've got the perimetrium, which is the outer protective membrane. Then the myometrium, that's the thick muscular middle layer. It's notably thickest at the top, the fundus, allowing for those powerful contractions needed during childbirth. And finally, the endometrium, the uterine lining, which actually has 2 sublayers. A functional layer that beautifully responds to estrogen and progesterone by growing and then shedding monthly, and a basal layer that acts like a regenerative factory, rebuilding the functional layer after menstruation. Also critical is the cervix, the narrow lower end of the uterus that connects to the vagina. It has a specific area called the transformation zone, where 2 types of cells meet. This zone is particularly vulnerable to the human papillomavirus, or HPV. As we'll discuss later, HPV infection here can lead to cervical dysplasia or even cancer. This is precisely the area where Pap tests collect cells for examination, making early detection possible. The cervix also acts as a clever gatekeeper. It produces thick, sticky mucus for most of the cycle, but dramatically thins and becomes stretchy. Almost like egg whites, they call it spin-barkite mucus during ovulation to help sperm get through.
Spin-barkite. Okay. Then we have the fallopian tubes, these delicate pathways extending from the uterus toward the ovaries. Their crucial job is to capture the released ovum and provide a safe passage. And fertilization, interestingly, usually occurs in their distal third, pretty far from the uterus itself. And finally, the ovaries, the female gonads. These are truly the most essential female reproductive organs. They're responsible for if you could see a cross-section of an ovary, like in figure 34.8 in the text, you'd basically see follicles in various stages of development, kind of like little potential eggs waiting their turn.
Let's pause on ovum production for a second. A woman is born with approximately 1 to 2 million primitive ova. That sounds like a lot, but this number drastically decreases to maybe 300,000 to 500,000 by puberty. And of those, only about 400 to 500 will actually mature and be released during a woman's entire reproductive lifespan. This finite supply is a really key difference from male reproduction. This continuous process of follicular maturation, ovulation, the release of that ovum, the development of the corpus luteum from the ruptured follicle, and its eventual degeneration if no fertilization occurs, is known as the ovarian cycle. It runs pretty much continuously from puberty until menopause.
Right. Now, let's talk about the stars of the show when it comes to female sex hormones: estrogen and progesterone. While androgens also play a minor role, estrogen is kind of a generic term for several similar hormones, with estradiol being the most potent and plentiful, primarily produced by the ovaries. Estrogen does so much. It helps maintain the nervous system, supports memory, increases skin collagen and elasticity, protects against kidney disease and vascular injury, and even inhibits platelet stickiness. But here's a key insight into its delicate balance. While protective in many ways, it can also ironically promote blood clotting and inflammation in certain contexts. It really highlights the complexity of our body's chemistry. And androgens, though primarily male sex hormones, are produced in small amounts in the female adrenal cortex and ovaries. They act as precursors to estrogens and contribute to the pubertal growth spurt, the growth of pubic and axillary hair, the activation of sebaceous glands, cue the acne, and they play a role in libido too. And then there's progesterone, primarily secreted by the corpus luteum, stimulated by LH. It's often aptly called the hormone of pregnancy because it does exactly that. It maintains the thickened endometrium, relaxes uterine smooth muscle to prevent premature contractions, promotes breast lobule and alveoli growth in preparation for lactation, and crucially, suppresses FSH and LH to prevent further ovulation during pregnancy.
Yeah, if you want a quick mental shortcut, you can really think of estrogen as the builder and progesterone as the maintainer when it comes to the uterine lining. Estrogen proliferates and prepares, while progesterone stabilizes and nourishes, making it receptive for implantation. It's a beautiful coordinated effort.
Okay, let's put these hormones and structures into motion to understand the menstrual cycle. That roughly 21 to 35 day rhythm average is 28 days, right? that profoundly affects female bodies. It involves an incredibly coordinated and synchronized dance between the ovary and the uterus. It's almost like a beautifully choreographed natural calendar of events. The cycle begins with the follicular or proliferative phase. In the ovary, FSH stimulates several ovarian follicles to grow, but usually only one dominant follicle is rescued from regression and selected for ovulation. As this follicle matures, estrogen levels steadily rise. This estrogen surge makes the cells within that follicle, called granulosa cells, more sensitive to FSH and also promotes LH stimulation. The crescendo is an LH and FSH surge, which is absolutely essential for the final growth of that dominant follicle and, crucially, for ovulation itself. Simultaneously, in the uterus, estrogen, our builder hormone, causes the endometrium to proliferate. That means it rapidly rebuilds itself after menstruation, thickening to prepare for a potential pregnancy.
Then comes ovulation, that dramatic, precise moment when the mature ovum is released from that dominant follicle. This event signals a pivotal shift, marking the beginning of the next phase.
And that next phase is the luteal or secretory phase. In the ovary, the ruptured follicle undergoes a remarkable transformation, becoming the corpus luteum, stimulated by that pulsatile LH. The corpus luteum then becomes a temporary endocrine gland, secreting a rich cocktail of progesterone, estrogen, and inhibin A. In the uterus, progesterone takes center stage. It stimulates the growth of glands and blood vessels within the endometrium, and these glands begin to secrete a glycogen-rich fluid, literally preparing the endometrium for the possibility of implantation. Estrogen, meanwhile, continues to maintain that endometrial thickness. Think of it like getting the guest room ready.
Exactly. Now, for the critical turn, if no conception occurs, the ischemic or menstrual phase begins. The corpus luteum, having served its purpose, degenerates. What happens next is a dramatic plummet in both progesterone and estrogen levels. This sharp decline in hormones is the direct trigger. The endometrium, now essentially starved of its hormonal support, disintegrates, and its functional layer is shed as menstruation, bringing the cycle right back to the beginning. That's the trigger.
And it's important to remember that these hormonal fluctuations don't just affect the uterus and ovaries. They also cause other subtle but significant changes throughout the body, like the thickness of the vaginal epithelium changes, cervical mucus transforms from thick and sticky to that clear, stretchy spinbar-type mucus around ovulation we mentioned, and there are even subtle shifts in your basal body temperature. The whole body is involved. Let's briefly touch on the breast now, starting with female breast development. Mammary growth is pretty dormant during childhood, right? But at puberty, it's stimulated by a powerful trio: growth hormone, IGF-1, insulin-like growth factor 1, and estrogen. The fularch, or breast development, is often the very first noticeable sign of puberty in females, but for full development, it takes a complex cocktail of hormones: estrogen, progesterone, prolactin, growth hormone, thyroid hormones, insulin, and cortisol all working together.
Yeah, it's quite a mix. And what's fascinating here is how your breasts respond to the monthly hormonal rhythm during your reproductive years. Estrogen primarily promotes the development of the ducts within the breast, while progesterone stimulates the acinar cells, which are responsible for milk production later on. So high estradiol levels during the follicular phase increase vascularity and tissue proliferation, making the breast feel fuller. Then, as progesterone levels rise in the luteal phase, they cause the ducts to dilate and convert those acinar cells into secretory cells. This is precisely why many women experience that familiar premenstrual fullness, tenderness, and increased breast nodularity, sometimes leading to an increase in breast volume of up to 30 milliliters, which is quite noticeable.
That's a great insight. And it's actually why breast self-exams or clinical breast exams are often best performed maybe a few days after menstruation ends. At that time, those hormonal effects are at their absolute minimum, and the breasts are typically at their smallest and least tender, making it easier to detect any unusual changes.
Now, for the male breast, development is quite similar to females until puberty. However, in males, the absence of consistently high levels of estrogen and progesterone, combined with the antagonistic effects of androgens, prevents further development. The normal male breast consists mostly of fatty tissue, a small nipple, and only a few rudimentary undeveloped duct-like structures. Some males, however, do experience benign gynecomastia during puberty, a temporary enlargement of the breast glandular tissue. This is usually due to hormonal fluctuations during that time, totally benign, but it's always important to differentiate it from any underlying health issues, just in case.
Okay, let's now shift our focus to the male reproductive system. Its overall function is pretty straightforward but vital: produce sperm and effectively deliver them to the female reproductive tract. This system, unlike the female system, has both external and internal genitalia with very distinct and specialized roles. Starting with the external genitalia, the testes are the essential organs of male reproduction. Just like the female ovaries, they have two crucial functions: producing gametes, which in this case are sperm, and producing sex hormones, primarily androgens like testosterone. During embryonic life, the testes actually develop up within the abdomen, then they embark on a journey, descending into the scrotum typically around 3 months before birth. Figure 34.13 in the text kind of shows this path.
Right. And if that descent fails, that's called cryptorchidism, which we'll touch on later. Now, to visualize the anatomy of a mature testes, like in figure 34.14, you'd find it divided into about 250 small lobules. Each of these lobules contains several coiled tubes called seminiferous tubules. These are the actual factories where sperm are produced. Nestled between these tubules, in clusters, are the Leydig cells. These are the guys responsible for churning out androgens, mainly testosterone.
And here's a really crucial physiological detail. The testes need to be approximately 1 degree to 7 degrees Celsius cooler than core body temperature for optimal sperm production. This is precisely why they're suspended outside the pelvic cavity within the scrotum. The body has these clever mechanisms to achieve this. Specialized blood flow regulation and the contraction or relaxation of scrotal muscles actively help to maintain that optimal cooler temperature. The scrotum itself is a protective, skin-covered fibromuscular sac. It's homologous to the female labia majora, actually. Its wrinkled appearance, the rugae, allows it to expand or contract. And beneath the skin, the tunica dartos muscle actively contracts in cold temperatures, pulling the testes closer to the warm body and relaxes when it's warm, allowing them to hang further away. This active temperature control is absolutely vital for sperm health. Plus, the scrotum is pretty sensitive, which provides some protection. And finally, the penis, which serves to deliver sperm during sexual intercourse and also eliminates urine. It's composed of 3 longitudinal compartments. Sexual arousal leads to an erection, an amazing feat of hydraulics, really. And ejaculation involves rhythmic contractions of various ducts and glands propelling semen out.
Okay, moving inside, the internal genitalia consist of a network of ducts and glands. The ducts, including the vasa deferentia, ejaculatory duct, and urethra, are essentially the transport system, carrying sperm and various secretions along the way. The glands, the prostate gland, seminal vesicles, and Cowper, or bulbourethral glands, are like the fluid factories. They produce the fluids that form semen. These fluids provide crucial nutrients and, importantly, an alkaline environment, which is absolutely vital for sperm motility and survival within the often acidic female reproductive tract.
Got it. And then there's spermatogenesis, the continuous process of creating sperm. This remarkable process begins at puberty, and unlike female oogenesis with its finite supply, continues throughout most of a man's life. Another key difference, it primarily takes place within those coiled seminiferous tubules of the testes, as shown in figure 34.1. The process starts with diploid spermatogonia, which are like stem cells, each with 46 chromosomes. These cells divide and mature through various stages, forming primary and secondary spermatocytes. These then undergo meiosis, that special cell division to become spermatids, each now with just 23 chromosomes. These spermatids then differentiate into mature spermatozoa, or sperm, which have that characteristic head and tail structure we see in diagrams like figure 34.80. This intricate differentiation is critically aided by the Sertoli cells we mentioned earlier. They act like nerve cells within the seminiferous tubules, providing essential nutrients and hormonal signals for sperm development.
Right. And when we talk about male sex and reproductive hormones, androgens, primarily testosterone, are the undisputed drivers. Testosterone is produced mainly by the Leydig cells in the testes, with smaller amounts coming from the adrenal glands. A key difference from the female system, as you said, is that male hormone production is relatively constant, not cyclic like the menstrual cycle. Physiologically, testosterone profoundly influences fetal differentiation of the urogenital system, drives the growth of sex organs at puberty, develops secondary sex characteristics like a deepening voice and increased muscle bone growth, stimulates sperm production, and is strongly linked to libido. It also has a surprising effect on bone marrow, increasing erythropoietin production and thus boosting hemoglobin and hematocrit levels.
Now, let's turn our attention to how these amazing and complex systems change with age. It happens to everyone, eventually. For the female reproductive system, the most significant and universal event is menopause. This is a normal, natural, developmental, and transitional event, usually occurring around age 51, though the range can be anywhere from 40 to 60. The period leading up to menopause is called perimenopause. This transitional phase can last anywhere from 1 to 8 years and is marked by highly variable menstrual flow. Cycles often shorten initially, then lengthen and become unpredictable, all due to increasingly irregular ovulation. Menopause itself is definitively defined retrospectively. 12 consecutive months without a menstrual period, that's the marker. It's characterized by the loss of ovarian function, which leads to dramatically low estrogen and progesterone levels. Consequently, as the text shows in Figure 34.9, you'll see a compensatory rise in FSH and LH levels as the pituitary tries harder and harder to stimulate the non-responsive ovaries. It's a clear hormonal signal of the transition. These profound hormonal shifts lead to several noticeable changes. Ovarian changes involve an accelerated loss of follicles, culminating in their eventual depletion. The ovaries actually decrease in size. Uterine changes include more anovulatory cycles, which can lead to proliferative growth of the endometrium and sometimes cause dysfunctional uterine bleeding. Hormonal changes are quite impactful. The rapid decrease in estrogen causes those well-known vasomotor flushes, or hot flashes, alongside mood swings, depression, anxiety, weight gain, and insomnia. Lower estrogen also decreases skin thickness and elasticity, causing dryness and wrinkling, and significantly increases the risk for two major health concerns: osteoporosis, which is bone weakening, and cardiovascular disease. This transition also subtly increases the risk of ovarian, breast, and uterine cancers, especially with certain reproductive histories like early menarche or late menopause, essentially more lifetime ovulations.
Right. In contrast, males retain their reproductive capacity significantly longer, and there's no single discrete menopause-like event. However, a gradual process known as andropause, or late-onset hypogonadism, does affect a smaller percentage of men as they age. It's more gradual, less defined. This process involves several contributing factors, including a gradual decrease in testosterone levels, subtle changes in how target tissues respond to hormones, a decrease in sex hormone binding globulin, SHBG, which means less free, active testosterone floating around, and subtle shifts in the hypothalamus and pituitary gland. Interestingly, obesity can also play a role in further decreasing testosterone production in aging males. The changes manifest in various ways. Erectile and ejaculatory capacity may require longer stimulation, ejaculations might be slower and less forceful, and the refractory time between ejaculations lengthens. Testicular changes can include decreased weight, atrophy, softening, and reduced sperm-producing activity and fertility. Hormonal shifts involve declining testosterone as the Leydig cells decrease in number and function, and a compensatory increase in gonadotropin levels. Associated changes can include a noticeable loss of muscle mass and strength, and a decrease in libido.
And while hormone replacement therapy can be considered for men experiencing significant symptoms of low testosterone, it's really crucial that the potential risks and benefits are carefully weighed and discussed with a healthcare provider for each individual. It's not a simple decision. Now we shift gears into part 2, focusing on alterations of the female reproductive system, drawing from chapter 35. Let's dive into what happens when these delicate and complex systems encounter challenges, going beyond those normal physiological changes we just discussed. We'll start with abnormalities of sexual maturation, essentially, when puberty goes a bit off script. Delayed puberty is defined as the failure of menarche, the first menstrual period, by age 13 without the development of any secondary sexual characteristics, or by age 15 even if some breast development or pubic hair is present. Most cases, thankfully, are simply a physiological or constitutional delay. This means the HPG axis is intact, but just operating on a slower timeline, often with a family history of late development. It just takes longer. Less commonly, it can be due to a disruption of that HPG axis itself, or a systemic disease like a genetic condition like Turner syndrome, or the effects of chemotherapy, or even severe weight loss.
And on the flip side is precocious puberty, which is the onset of sexual maturation before 8 years of age in girls. This isn't just about early development. It's about the potential impact it can have. There are different types. Central, or GnRH-dependent, precocious puberty involves a premature but otherwise normal functioning of the HPG axis. This can be idiopathic, meaning we don't know the cause, or it can be linked to CNS disorders like certain tumors, like a hypothalamic hamartoma. Then there's peripheral, or GnRH-independent, precocious puberty. Here, inappropriate sex hormone production comes from sources outside the normal HPG axis, like adrenal hyperplasia, or ovarian cysts or tumors, or even exposure to external sex steroids. There's also a mixed type where you might see some characteristics of the opposite sex developing. The primary concern with complete precocious puberty, whether central or peripheral, is that the early rush of hormones can lead to premature fusion of the growth plates and bones, ultimately affecting adult height. Treatment aims to identify and remove the underlying cause if possible, or administer hormones to kind of pause puberty, ensuring proper development.
Okay, moving on to disruptions of the monthly cycle itself. Let's talk about dysmenorrhea, which is simply pelvic pain associated with menstruation. It's incredibly common. Primary dysmenorrhea is the type where there's no underlying pelvic disease. It results from an overproduction of natural inflammatory chemicals in the uterus, primarily prostaglandin F2. PGF2. These prostaglandins are potent stimulants of the myometrium, the uterine muscle, and also vasoconstrictors. So high levels increase contractions, constrict blood vessels, and enhance nerve sensitivity, leading to pain and ischemia, that familiar cramping feeling.
Exactly. And this helps us understand why NSAIDs, non-steroidal anti-inflammatory drugs, are often the first-line treatment for primary dysmenorrhea. They directly work by reducing prostaglandin production. Simple as that. Hormonal contraceptives can also help by suppressing ovulation and creating a thinner, atrophic endometrium, which produces fewer prostaglandins. Secondary dysmenorrhea, however, is caused by an underlying disorder, such as endometriosis, where tissue similar to the uterine lining grows outside the uterus, or endometritis, PID, uterine fibroids, polyps, even IUDs. Here, treating the underlying condition is the key to relieving the pain. Symptoms often radiate more widely, too.
Right. Next, amenorrhea, which is the absence of menstruation. Primary amenorrhea is the failure of menarche by age 13 without secondary sexual characteristics, or by age 15 regardless of secondary characteristics. Secondary amenorrhea is the absence of menses for 3 or more cycles in women who have previously menstruated. Beyond pregnancy, which is the most common cause, other culprits include thyroid disorders, hyperprolactinemia, hyperlactin levels, disruptions to the HPO axis, hypothalamic pituitary ovarian axis, due to factors like excessive exercise, severe stress, or significant weight loss, and polycystic ovary syndrome, PCOS, which we'll get to shortly.
hmm And when diagnosing amenorrhea, doctors often think in terms of different compartments, like levels of potential problems. You can almost visualize it as a diagnostic tree, like in Figure 35.2. Compartment I involves anatomic defects, like maybe the uterus or vagina didn't form properly. Compartment 2 points to ovarian disorders, like Turner syndrome or maybe androgen insensitivity syndrome, AIS, where the body can't respond to androgens, leading to a lack of estrogen effects. Compartment 3 involves anterior pituitary gland disorders, like tumors affecting FSHLH secretion, and Compartment 4 covers CNS or hypothalamic defects that prevent GnRH secretion right at the top. Treatment, of course, depends entirely on identifying and correcting the underlying disorder.
Okay, another common issue is abnormal uterine bleeding, AUB. This is defined as bleeding that is abnormal in duration, volume, frequency, or regularity, and has been present for the majority of the last 6 months. When doctors investigate AUB, they use a structured system called PAL-M-CAWA-IN. It's an acronym shown in Figure 35.3 to categorize the potential causes. The PAL-M part covers structural causes: polyp, adenomyosis, leiomyoma, fibroids, and malignancy hyperplasia. The KOEIN part covers non-structural causes: coagulopathy, bleeding disorders, ovulatory dysfunction, endometrial causes, iatrogenic, like from medications or IUDs, and not yet classified. It helps organize the thinking. Clinically, AUB can manifest as unpredictable bleeding, sometimes very heavy with clots, especially common in perimenopause, and it can lead to iron deficiency anemia. Treatments range from NSAIDs or hormonal therapies like progesterone-releasing IUDs or oral contraceptives to more invasive options like ablation or hysterectomy for severe cases if future pregnancy isn't desired. But here's that crucial takeaway again. Any vaginal bleeding in postmenopausal women needs immediate investigation by a doctor to rule out cancer. Cannot stress that enough.
Absolutely. Now let's talk about polycystic ovary syndrome, PCOS. This is one of the most common endocrine disturbances in women, affecting maybe 5–10% of women of reproductive age, and it's a leading cause of infertility. Now, when you hear polycystic ovaries, you might imagine ovaries just covered in large cysts, like in Figure 35.4, which shows an enlarged ovary with a smooth, pearly white capsule. But that's not always the case, and they don't have to be present for a diagnosis. The diagnostic criteria typically require at least 2 of the following 3 things: irregular or absent ovulation, elevated androgen levels, clinically or biochemically, or polycystic ovaries seen on ultrasound. And importantly, it's a diagnosis of exclusion. Other conditions need to be ruled out first. The pathophysiology of PCOS is truly fascinating and complex. It's often described as this perfect storm involving genetic predisposition, obesity, and centrally a core problem of insulin resistance leading to hyperinsulinemia, meaning high insulin levels, which then drives hyperandrogenism and excess of male hormones. Here's how it seems to work. Insulin resistance causes your body to pump out more insulin to compensate. This excess insulin then overstimulates the ovaries to secrete more androgens. It also reduces SHBG, sex hormone binding globulin, a protein that normally binds to testosterone, meaning there's more free active testosterone circulating. These excessive androgens, in turn, disrupt follicular development, leading to premature follicular failure and persistent ovulation. Insulin itself also seems to suppress follicle apoptosis, or programmed cell death. So it's a vicious cycle where obesity can aggravate the condition, and PCOS itself predisposes to obesity and further insulin resistance.
Wow, yeah, vicious cycle. The clinical manifestations of PCOS usually appear within 2 years of puberty or sometimes later in life. They include dysfunctional uterine bleeding or amenorrhea, hirsutism, which is abnormal hairiness in male-like patterns, acne, sometimes a skin condition called acanthosis nigricans, and infertility.
Yeah.
And importantly, PCOS is often associated with other significant health issues, including obesity, hypertension, dyslipidemia, abnormal blood fats, sleep apnea, and a significantly increased risk of developing type 2 diabetes and uterine cancer later in life. It's a condition with really far-reaching health implications. We should also briefly mention premenstrual disorders like PMS, premenstrual syndrome, and the more severe PMDD, premenstrual dysphoric disorder. These involve a cyclic recurrence of distressing physical, psychological, or behavioral changes that happen specifically during the luteal phase of the menstrual cycle, and they're severe enough to impair relationships or daily activities. PMDD is basically a more severe, disabling form of PMS.
The pathophysiology is complex and not fully understood, but it seems to involve an increased vulnerability or sensitivity to normal fluctuations in ovarian hormones, particularly estrogen and progesterone. There might also be interactions with neurotransmitters like serotonin, GABA, and norepinephrine, and changes in the HPA axis, the stress response system. Genetics likely play a role too. Clinically, there are nearly 300 reported symptoms, but the emotional ones, depression, anger, irritability, fatigue, are often the most prominent. The key is the pattern of symptoms, recurring predictably in the luteal phase and resolving after menstruation starts. Treatment focuses on symptomatic relief, ranging from lifestyle changes like exercise and stress reduction to hormonal regulation with contraceptives or SSRI antidepressants for mood symptoms. Okay, let's move on to infection and inflammation, a very significant category of female reproductive alterations. Infections can be exogenous, meaning they come from outside the body, most notably sexually transmitted infections or STIs. Or they can be endogenous, resulting from an overgrowth or migration of normal bacterial flora that typically reside harmlessly in the vagina or bowel.
A major concern here is pelvic inflammatory disease, PID. This is an acute inflammatory process affecting the upper genital tract, the uterus, fallopian tubes, and ovaries. If you could visualize it like in figures 35.6 and 35.7, you might see the fallopian tubes becoming severely swollen and inflamed, that's salpingitis, maybe the ovaries too, oophorytis, potentially even filled with pus, pyosalpinx, and forming extensive adhesions or scar tissue. It's a serious condition with potentially lasting consequences.
PID is most commonly caused by untreated STIs, particularly gonorrhea and chlamydia, which can migrate upwards from the vagina and cervix. Other risk factors include having multiple sex partners, a previous history of PID, douching, which can disrupt the normal flora, and sometimes IUD use, especially shortly after insertion. The pathophysiology involves these microorganisms ascending, basically getting past the body's natural defense mechanisms. Gonococcus, for instance, can attach to and damage the lining of the fallopian tubes. Chlamydia actually replicate inside the cells, causing scarring that significantly increases the risk of ectopic pregnancy, a life-threatening condition where a fertilized egg implants outside the uterus, usually in the fallopian tube. Complications of PID are serious and include infertility, chronic pelvic pain, intestinal obstruction due to adhesions, and, as mentioned, that higher risk of ectopic pregnancy. Because symptoms can sometimes be vague, maybe just lower abdominal pain or tenderness, the CDC actually encourages doctors to consider PID and start treatment empirically if a sexually active woman presents with pelvic or lower abdominal tenderness, plus tenderness when the cervix is moved, or tenderness in the uterus or adnexa, the area around the ovaries and tubes. Treatment typically involves broad-spectrum antibiotics like ceftriaxone, doxycycline, and metronidazole to cover the likely pathogens. And critically, all recent sexual partners must also be treated to prevent reinfection and further spread. Annual STI screening for at-risk women is crucial for prevention.
Right. Related to this, let's quickly touch on vaginitis, which is irritation or inflammation of the vagina. It often causes itching, burning, odor, or abnormal discharge. It can be caused by an overgrowth of normal flora, like bacterial vaginosis or a yeast infection, vulvovaginal candidiasis, STIs, like trichomoniasis, or even low estrogen levels, as seen in atrophic vaginitis after menopause. The key insight here is that vaginitis is largely linked to alterations in the vaginal environment, especially its pH. The vagina is normally acidic, pH 4 through 4.5, maintained by beneficial Lactobacillus acidophilus bacteria. Factors that raise this pH, like semen, douching, certain soaps, spermicides, even some antibiotics, can disrupt the balance and predispose to infection. Treatment involves restoring that acidic environment and using appropriate antimicrobials.
And another important inflammatory condition is cervicitis, inflammation of the cervix. This often presents with a purulent or pus-like discharge coming from the cervical opening, or easy bleeding, particularly after intercourse or during an exam. Like PID, it can be caused by STIs like chlamydia, Neisseria, gonorrhea, or trichomonas. Untreated cervicitis, particularly mucopurulent cervicitis, MPC, can be a gateway to PID, highlighting the interconnectedness of these infections. Sometimes, if a young, at-risk woman has MPC, she might be treated for PID empirically just to be safe.
Okay, what about chronic pain? There's a condition called vulvodynia, VAV. This is chronic vulvar pain lasting more than 3 months, often described as burning, stinging, or soreness, especially with touch or pressure, like during intercourse, dyspareunia. It's actually quite common, affecting maybe 10–28% of reproductive age women.
Yeah, and the causes are still poorly understood, likely multifactorial. Theories range from embryonic factors, chronic inflammation from various sources, immune factors, nerve pathway sensitization, maybe even dietary oxalates. It might involve the vulvar tissue itself, the pelvic floor muscles, and even central nervous system pain processing. Treatment is challenging and multifaceted, involving avoiding irritants, using topical anesthetics or estrogen creams, sometimes antidepressants or Botox, physical therapy for pelvic floor relaxation, counseling, and in some severe cases, surgery called vestibulectomy.
And briefly, bartholinitis, or a Bartholin cyst. This is an infection of the Bartholin glands, which are located near the vaginal opening. If the duct gets blocked, a cyst can form, which can then get infected and become an abscess. Figure 35.8 shows this. It's usually red, painful, sometimes with visible pus. Treatment involves draining the cyst or abscess and antibiotics. Now let's discuss pelvic organ prolapse, POP. This involves a loss of support for pelvic organs, leading to their descent or dropping down. The bladder, urethra, rectum, and uterus are normally held securely in place by a network of connective tissue called endopelvic fascia and strong perineal muscles, the pelvic floor. But with factors like aging, the trauma of childbirth, especially multiple vaginal deliveries, obesity, or chronic conditions that increase intra-abdominal pressure, like a persistent chronic cough or chronic constipation, these supporting tissues can lose their tone and strength. When that happens, one or more pelvic organs can descend from their normal position into or even outside the vagina.
Right, you can imagine various types of prolapse, and figures 35.9 and 35.7 you saw and help visualize this. Uterine prolapse is when the cervix or the entire uterus descends into the vaginal canal. In more severe grades, like grade 2 or 3, it can cause feelings of fullness, heaviness, dragging, and significant discomfort. In the most severe cases, the uterus actually protrudes from the vaginal opening, the introitus. A cystocele is when the posterior bladder wall sags or bulges into the anterior vaginal canal, often resulting from childbirth trauma. This can cause vaginal pressure, aggravated by activity, and sometimes urinary symptoms like incomplete emptying or stress incontinence. A rectocele is the bulging of the rectum and posterior vaginal wall into the posterior vaginal canal. This can be exacerbated by chronic constipation and may cause feelings of rectal fullness, difficulty evacuating stool completely, or needing to press on the perineum to defecate. And an enterocele is a herniation of the rectuterine pouch, which is the space between the rectum and the posterior vaginal wall, usually containing small bowel. These conditions all share common risk factors, including aging, obesity, hysterectomy, which can sometimes weaken support, childbirth trauma, a possible familial tendency, and anything that chronically increases pressure, like heavy lifting or chronic lung disease.
So what about treatment? It really varies depending on the severity and the woman's symptoms and preferences. Conservative approaches include pessaries, which are removable devices inserted into the vagina to physically hold the organs in place. They come in various shapes and sizes. Kegel exercises are crucial for strengthening the pelvic floor muscles, specifically the pubococcygeus muscles, and for postmenopausal women, estrogen therapy might help improve tissue tone. Lifestyle modifications are also really important. Maintaining a healthy BMI, preventing constipation with diet and fluids, and treating conditions like chronic cough. Surgical repair is often a last resort for severe symptomatic cases and might involve repairing the supporting tissues, sometimes with or without a hysterectomy.
Yeah, and here's that crucial insight regarding surgical treatment again. Surgical mesh, which was used for a time to reinforce pelvic organ prolapse repairs, has been associated with a high rate of significant complications, things like infection, persistent pain, erosion of the mesh into surrounding organs like the vagina or bladder, and mesh shrinkage, causing more pain. In fact, the FDA has taken pretty strong action, ordering manufacturers to stop selling and distributing surgical mesh products specifically for transvaginal repair of POP in the U.S. due to these safety concerns. This really highlights the importance of carefully weighing all treatment options, discussing risks thoroughly, and understanding potential long-term outcomes.
Okay, let's turn our attention now to benign growths and proliferative conditions. These are non-cancerous changes that can still cause significant symptoms or concerns. Ovarian cysts are very, very common, especially during the reproductive years when hormonal fluctuations are at their peak, but also sometimes around puberty or menopause when hormones can be imbalanced. Figure 35.11 shows some examples. They are often called functional cysts because they arise from normal physiological variations of the menstrual cycle. Two main types are follicular cysts. These form when a dominant follicle fails to rupture and release the ovum, or when non-dominant follicles don't regress properly, they're just fluid-filled sacs. Then there are corpus luteum cysts, which occur when the corpus luteum persists abnormally instead of degenerating after ovulation. These can sometimes grow quite large and may bleed internally, causing pain. Both follicular and corpus luteum cysts can cause pelvic pain, bloating, tender breasts, or heavy irregular menses. But the good news is they usually regress spontaneously within a few cycles. Oral contraceptives can help prevent future functional cysts by suppressing ovulation. Another type, a dermoid cyst, is different. It's a type of benign germ cell tumor called an ovarian teratoma. These can contain tissues from all three embryonic germ layers, meaning you might find things like skin, hair, teeth, bone, or thyroid tissue inside them. While often asymptomatic, they do have a small malignant potential and always warrant careful evaluation and often removal.
Mhm. Next, we have endometrial polyps. These are benign masses of endometrial tissue that project into the uterine cavity. They can be hyperplastic, atrophic, or functional, responding to hormones. They are a common cause of intermenstrual bleeding or excessive menstrual bleeding, menorrhagia. Risk factors include increasing age, obesity, nulliparity, never having given birth, conditions with high estrogen levels, and interestingly, the use of tamoxifen, a breast cancer drug that can have estrogenic effects on the uterus. Diagnosis is often made by transvaginal sonography or hysteroscopy, looking inside the uterus with a camera. Many resolve spontaneously, but symptomatic ones can be easily removed.
Okay, now for a big one, leiomyomas, more commonly known as myomas or uterine fibroids. These are the most common benign tumors of the uterus, developing from the smooth muscle cells in the myometrium. They affect a significant number of women, up to 70–80% by age 50, though many are asymptomatic and never cause problems. Their prevalence increases between ages 30–50, and they typically shrink after menopause. Here's an interesting fact. Black and Asian women have a higher incidence, and fibroids tend to develop at an earlier age in Black women.
Right. While the exact cause is unknown, we know their growth is heavily influenced by estrogen and progesterone, which is why they tend to enlarge during pregnancy or with hormonal therapies and shrink after menopause when hormone levels drop. Growth factors and reduced apoptosis, programmed cell death, also play a role. Risk factors include heredity, nulliparity, obesity, PCOS, race, maybe hormone use, and hypertension. Pathophysiologically, they often occur in multiples and are usually found in the fundus, the top part of the uterus. They're classified by their location, subserous, on the outer surface, submucous, bulging into the uterine cavity, often causing bleeding, or intramural, within the uterine wall. Figure 35.13 shows this clearly. Sometimes they can outgrow their blood supply, causing degeneration and pain. Research has found mutations in a gene called MED12 in about 70% of fibroids.
Clinically, they can manifest as abnormal vaginal bleeding, often very heavy periods, menorrhagia, pain, especially degenerating, or pressure on nearby structures like the bladder, causing urinary frequency or urgency, or the rectum, causing constipation. They can also contribute to infertility or problems during pregnancy or birth. For treatment, small asymptomatic fibroids are often just observed. Medical options include hormonal contraceptives or other agents to shrink them or reduce bleeding. Surgical options range from myomectomy, removing only the fibroids to preserve fertility, to hysterectomy, removing the uterus for severe cases or fertility isn't desired. Other options like uterine artery embolization, UAE, or laser ablation exist, but UAE might have higher complication rates down the line.
And briefly, adenomyosis. This is a condition where endometrial tissue, the glands and stroma normally lining the uterus, is present within the uterine myometrium, the muscle wall. It's often diagnosed later in reproductive years or incidentally after a hysterectomy. Risk seems higher with increased parity, number of births, and tamoxifen use. Symptoms can range from none to abnormal bleeding, anemia, progressively severe dysmenorrhea, menstrual pain, uterine enlargement and tenderness, chronic pelvic pain, and infertility. Treatment is often symptomatic with NSAIDs or hormonal therapies like LNG IUDs, or ultimately hysterectomy for definitive treatment.
Finally, in this benign category, we have endometriosis. This is a condition where functioning endometrial tissue or implant grows outside the uterus. This ectopic tissue acts just like the uterine lining. It responds to the menstrual cycle hormones, so it proliferates, breaks down, and bleeds each month. But because this blood and tissue breakdown occurs outside the uterus, it has nowhere to easily exit the body. This leads to inflammation, chronic pain, and the formation of scar tissue or adhesions in the surrounding areas, potentially sticking organs together. Common sites for these implants, as shown in Figure 35.4c, include the pelvic peritoneum, the lining of the pelvic cavity, the ovaries, where they can form cysts called endometriomas or chocolate cysts, the uterine ligaments, and the rectovaginal septum, the space between the rectum and vagina. It primarily affects younger, premenopausal women, peaking in the third decade. It's highly associated with chronic pelvic pain, infertility, and pelvic masses. It's actually the third most common reason for hysterectomy and carries a slightly higher risk for developing ovarian cancer.
Mm-hmm. The clinical manifestations vary widely in frequency and severity, often mimicking other pelvic diseases, which can make diagnosis tricky. Key symptoms include infertility, affecting maybe 25–40% of women with endometriosis, persistent pelvic pain, often cyclical but can become chronic, dyschezia, painful defecation, dyspareunia, painful intercourse, constipation, and abnormal vaginal bleeding. Here's a really surprising point. The degree of the disease seen visually often doesn't correlate well with the severity of symptoms. Someone might have minimal disease visually but experience debilitating pain, while others with extensive disease might have fewer symptoms. It's very individual.
Diagnosis is often presumptive based on symptoms, but the definitive diagnosis requires visualization, usually via a surgical procedure called pelvic laparoscopy, where the implants can be seen and classified: minimal, mild, moderate, severe. Treatment aims to prevent progression, alleviate pain, and restore fertility if desired. Medical options focus on suppressing ovulation and hormonal activity using things like combined oral contraceptives, progestins like DMPA injections or LNG IUDs, GnRH agonists which induce a temporary menopause-like state, or older drugs like danazol. Conservative surgical treatment involves laparoscopically removing or destroying the implants. Unfortunately, recurrence is common even after treatment.
Okay, now we need to discuss a serious and vital topic: cancers of the female reproductive system. Let's begin with cervical cancer. This cancer is almost exclusively caused by persistent infection with certain high-risk types of human papillomavirus, or HPV. HPV infection is considered a necessary condition for the development of almost all precancerous lesions, dysplasia, and invasive cervical cancers. This direct causal link makes prevention incredibly important. Key risk factors include having multiple sex partners, young age at first intercourse, high parity, many pregnancies, persistent infection with high-risk HPV types, especially HPV-16 and HPV-18, immunosuppression, like with HIV, long-term oral contraceptive use, though the reasons aren't fully clear, and maybe even douching, which can alter the protective vaginal microbiome. Interestingly, healthy vaginal microbiomes dominated by lactobacilli seem to reduce HPV prevalence. Pathophysiologically, the cervix is lined by two types of cells: squamous cells in the outer part, ectocervix, and glandular columnar cells lining the inner canal, endocervix. The area where these two cell types meet is called the squamocolumnar junction or transformation zone. Figures 35.15 and 35.16 show this. This zone is highly dynamic, especially during puberty and pregnancy, and is particularly vulnerable to infection by oncogenic HPV types. HPV infects the immature basal cells here, integrating its DNA and producing viral proteins that disrupt normal cell cycle control, leading to uncontrolled proliferation and potentially cancer over time. Squamous cervical precursor lesions are classified along a spectrum, often using terms like dysplasia, carcinoma in situ, CIS, cervical intraepithelial neoplasia, CIN13, or squamous intraepithelial lesion, LSIL for low-grade, HSIL for high-grade, as outlined in Table 35.4. Carcinoma in situ, CIS, represents the proliferation of abnormal epithelial cells that is still confined by the basement membrane. It hasn't invaded deeper tissues yet. Here's the critical takeaway. Prevention is paramount. HPV vaccination, like Gardasil 9, is highly effective and recommended for adolescents and young adults before sexual debut. Condom use reduces transmission but doesn't completely eliminate risk as it doesn't cover all potentially infected areas. And regular Pap tests, cytology, and/or HPV testing allow for early detection and treatment of precancerous lesions, dramatically reducing the incidence of invasive cervical cancer in screened populations.
Right. Moving on to vaginal cancer. This is actually the rarest of the female genital cancers. Its epidemiology is quite similar to cervical cancer, also strongly linked to HPV infection. Risk factors include prior cervical or uterine carcinoma, and notably, in utero exposure to a synthetic estrogen called diethylstilbestrol, DES, which was given to pregnant women decades ago and later found to cause a rare type of vaginal cancer, clear cell adenocarcinoma, in their daughters. Smoking and previous STIs are also risk factors.
Then there's vulvar cancer, which often affects the labia majora. Its incidence seems to be increasing, possibly related to HPV. Risk factors again include HPV infection, especially type 16, HIV infection, increasing age, a history of untreated high-grade vulvar intraepithelial neoplasia, their precursor lesion, a history of cervical cancer, certain autoimmune conditions, immunosuppression like in organ transplant recipients, and tobacco use. It's often preceded by condyloma, warts, or squamous dysplasia.
Okay, now let's discuss endometrial cancer. This is the most common type of uterine cancer and the most prevalent gynecologic malignancy overall, as shown in figure 35.17. It predominantly affects postmenopausal women with a peak incidence in their late 50s to early 60s. Sadly, there are disparities with higher death rates in Black women who are often diagnosed at later stages. The pathophysiology is strongly associated with prolonged estrogenic stimulation, or what we call unopposed estrogen. This happens when estrogen stimulates the growth and proliferation of the endometrial lining without sufficient progesterone to balance and inhibit that growth. Progesterone normally counteracts estrogen's proliferative effect. This imbalance leads to endometrial hyperplasia, which is an overgrowth and thickening of the endometrium that can progress to become cancerous.
You can visualize this balance in figure 35.19, showing estrogen, E2, and progesterone, P4, and their receptors. Misregulation of progesterone receptor isoforms can potentially foster hyperplasia. Endometrial cancers are broadly classified into two types, summarized in table 35.5. Type 1 is the most common, about 80%, is associated with that unopposed estrogen exposure, often arises from hyperplasia, and generally has a better prognosis. Type 2 is less common, often occurs in older women, is not typically associated with estrogen excess, tends to be more aggressive, like serous or clear cell types, and has a poorer prognosis. Risk factors for type I cancer really center around that unopposed estrogen. Estrogen-only hormone replacement therapy, tamoxifen use, acts like estrogen on the endometrium, early menarche, late menopause, nulliparity, chronic anovulation, like in PCOS. Other factors linked to both types include chronic hyperinsulinemia, hyperglycemia, diabetes, obesity, fat cells produce estrogen via aromatase, adult weight gain, chronic inflammation, and lack of physical exercise.
The most common clinical manifestation, and a critical warning sign you should never ignore, is abnormal vaginal bleeding, especially any bleeding after menopause. That's the cardinal symptom. Pain and weight loss usually indicate more advanced disease. Diagnosis often starts with the transvaginal ultrasound, TVUS, to measure the endometrial thickness. If it's thick, generally 5 millimeters in a postmenopausal woman, or if bleeding persists, an endometrial biopsy is needed for definitive diagnosis. Treatment depends heavily on the stage and type, ranging from progestin therapy for simple hyperplasia to surgery, hysterectomy with removal of tubes and ovaries, radiation, and chemotherapy for invasive cancer.
Finally, ovarian cancer. This cancer causes more deaths than any other female genital cancer. This grim statistic is largely due to a lack of early specific symptoms and the absence of truly effective screening tests for the general population. When symptoms do occur, like bloating, pelvic pressure, abdominal pain, feeling full quickly, they are often vague and easily attributed to other things, leading to diagnosis at later stages when the cancer has already spread. Risk factors include advancing age, genetic factors, mutations in BRCA1, BRCA2 genes significantly increase risk, as does a family history, being overweight or obese, height, certain reproductive hormonal factors like hormone replacement therapy, possibly endometriosis, diabetes, previous cancer, smoking, and maybe environmental exposures like asbestos or talc-based powder, though the link with talc is controversial. Interestingly, the risk is reduced by factors that suppress ovulation, such as multiple pregnancies, prolonged breastfeeding, and the use of combined hormonal contraceptives. This supports the theory that repeated ovulation and repair of the ovarian surface might contribute to cancer development over time.
Right. And here's that major paradigm shift in our understanding again. Historically, we thought most ovarian cancers arose primarily from the epithelial cells covering the surface of the ovary. However, newer compelling evidence suggests that many high-grade serous ovarian cancers, the most common and lethal type, actually originate from precursor lesions called serous tubal intraepithelial carcinoma, or STIC lesions, in the delicate fimbriae of the fallopian tubes, those finger-like projections at the end of the tubes that pick up the egg. Some endometrioid and clear cell types may arise from deposits of endometriosis. Other rarer types arise from germ cells or stromal cells within the ovary.
hmm The histologic types vary, with Cerdes being the most common high-grade type, but also mucinous and endometrioid, shown in Figure 35.21b. This understanding of the fallopian tube origin for many high-grade serous cancers has fundamentally changed surgical recommendations for high-risk women, such as those with BRCA mutations. Prophylactic salpingo-oophorectomy, preventative removal of both fallopian tubes and ovaries, often done around age 35-40 or after childbearing is complete, is now standard practice to drastically reduce their risk. Some are even exploring just removing the fallopian tubes, appendectomy initially, leaving the ovaries for hormonal function longer.
Treatment for diagnosed ovarian cancer typically involves surgery as the initial approach, both for staging the cancer accurately and for maximal tumor debulking or removal, cytoreduction. Survival rates are strongly linked to how much tumor can be removed by the surgeon, emphasizing the importance of specialized gynecologic oncologists. Surgery is usually followed by customized chemotherapy and sometimes radiation or targeted therapies. New therapies are constantly under investigation due to the challenges in treating advanced disease. Let's delve into a very sensitive and complex area now: sexual dysfunction in females. This is broadly defined as a lack of satisfaction with sexual function due to pain or a deficiency in desire, arousal, or orgasm. It's incredibly influenced by a complex interplay of personal, biological, psychological, relationship, and cultural factors, and it's far more common than many people realize, often underreported due to embarrassment or stigma. We can break it down into a few common challenges. Disorders of desire, like hypoactive sexual desire disorder or decreased libido, are probably the most common complaint, and they often increase with age. These can be linked to depression, anxiety, relationship dissatisfaction, history of sexual or physical abuse, alcohol substance abuse, hormonal issues like high prolactin or low testosterone, or side effects from medications like beta blockers or antidepressants. Anorgasmia or orgasmic dysfunction is the inability to reach orgasm despite adequate stimulation. This can be linked to chronic illness like diabetes, neurologic disturbances, hormonal deficiencies, pelvic disorders causing pain or nerve damage, or again, certain drugs like narcotics, SSRIs, antihypertensives. Dyspareunia, or painful intercourse, can involve pain occurring anywhere from initial arousal to long after intercourse, often described as burning, sharp, or cramping. Causes are numerous. Inadequate lubrication due to drugs, diabetes, infections, or low estrogen after menopause causing vaginal atrophy. Skin disorders, infections, pelvic floor muscle tension, or underlying pelvic disorders like endometriosis, PID, or tumors. And vaginismus is an involuntary spasm of the pelvic floor muscles in response to attempted vaginal penetration, making intercourse difficult or impossible. This often has psychological roots related to trauma, fear, or anxiety about sex, but can also be linked to organic causes similar to those causing dyspareunia or conditions like vulvodynia.
What's crucial to understand, and this applies to both men and women, is that sexual dysfunction can sometimes be a physical manifestation of deeper issues, perhaps even a subconscious coping mechanism related to past trauma, relationship conflicts, or stress. Therefore, any assessment and treatment must always be holistic and culturally sensitive. It requires addressing not just the physical symptoms, but also the emotional, psychological, interpersonal, and social dimensions of a person's life. It's almost never just a single, simple factor.
Moving on to impaired fertility in females. This is defined as the inability to conceive after 1 year of unprotected intercourse with regular frequency. It affects approximately 15% of couples trying to conceive. For females, key contributing factors can include tubal factors like blockage or damage to the fallopian tubes, often from scarring due to conditions like endometriosis or previous pelvic inflammatory disease, PID. Ovulatory factors are also common, including anovulation, the failure to ovulate regularly, or problems with ovum maturation or release, often related to hormonal imbalances like in PCOS or thyroid disorders, and uterine factors like an inability of a fertilized ovum to implant successfully due to an unreceptive endometrium, perhaps because of uterine fibroids distorting the cavity, uterine anomalies, polyps, or inadequate molecular or cellular preparation of the lining.
Evaluation typically starts with the least invasive approaches first. This includes a comprehensive history covering menstrual cycles, timing of intercourse, previous pregnancies, medical history, medications, surgeries, past STIs, and potential toxin exposures. Then comes a pelvic exam, transvaginal ultrasound to look at the uterus and ovaries, and often a hysterostalpingogram, HSG, which is an X-ray procedure using dye to check for fallopian tube patency, openness. Hormonal assays, checking FSH, LH, estrogen, progesterone, thyroid, prolactin levels at specific times in the cycle, and sometimes chromosomal analyses might also be needed. When natural conception is challenged, assisted reproductive technologies, ARTs, like in vitro fertilization, IVF, have proliferated and helped many couples conceive. However, this raises important ongoing research questions about the health and safety of ART infants, who consistently show slightly higher rates of multiple births, twins, triplets, preterm births, low birth weight, and certain birth defects compared to naturally conceived infants. This might be due to the RT procedures themselves, causing epigenetic changes, or perhaps related to the underlying infertility conditions in the parents. And connecting this back to our earlier discussion, preventing STIs is a crucial primary prevention strategy to reduce the risk of tubal scarring and adhesions, which remain a common and often preventable cause of female infertility.
Now, let's explore disorders of the female breast, starting with some non-cancerous conditions. Galactorrhea means inappropriate lactation. This is the persistent or excessive secretion of milky fluid from the breasts in women who are not pregnant or nursing. It can also occur, though rarely, in men. Importantly, galactorrhea itself is not associated with breast cancer. The causes are varied, but primarily involve hyperprolactinemia, which is elevated levels of the hormone prolactin. This can stem from problems with the hypothalamus or pituitary gland, such as a benign tumor called a pituitary adenoma that secretes prolactin. Other causes include certain CNS disorders, chronic renal failure, hypothyroidism, various drugs, especially antipsychotics, some antidepressants and antihypertensives, or even chronic stress. Sometimes excessive nipple stimulation or chest wall irritation can trigger it. Clinically, it presents as milky breast secretion, often accompanied by menstrual abnormalities like amenorrhea, or infertility if a pituitary issue is involved, or maybe CNS symptoms like headache or visual disturbances if there's a large adenoma. Evaluation involves measuring serum prolactin levels. Levels 75-100 GMLHE strongly suggest a tumor, checking thyroid function, T4-TSH, and LH-FSH. An MRI of the pituitary is usually done if prolactin is significantly elevated or a tumor is suspected. Treatment focuses on identifying and treating the underlying cause, often with medication to lower prolactin levels.
Right. Next, we have benign breast disease, BBD, which is a really broad umbrella term for a range of non-cancerous changes in the breast, including lumps, cysts, pain, and nipple discharge. These are, in fact, the most common breast symptoms women report to their doctors. The key question often is, does this benign condition increase the risk for developing breast cancer later? The answer depends heavily on the specific histologic microscopic features, whether there was atypia found on a prior biopsy, and the woman's family history. BBD is generally classified in three main groups based on cancer risk. 1. Non-proliferative lesions. These are not associated with an increased risk of breast cancer. Examples include simple breast cysts, very common fluid-filled sacs, papillary apocrine change, and mild hyperplasia of the usual type. Simple cysts generally don't require treatment unless they are large and symptomatic. 2. Proliferative breast disease without atypia. This is a diverse group with a slight or potentially no increased risk, maybe 1.5 to 2 times the baseline risk.
Examples include usual ductal hyperplasia, UDH, intraductal papillomas, growths within ducts, often causing nipple discharge, sclerosing adenosis, radial scars, and simple fibroadenomas. Fibroadenomas are common benign, solid tumors made of glandular and fibrous tissue. They are often found in younger women, 15 to 35, feel firm and rubbery, are typically mobile, and often regress after menopause. Simple fibroadenomas don't significantly increase cancer risk. 3. Proliferative breast lesions with atypia, atypical hyperplasia AH. This is the category that signals a significantly increased risk. Here, the proliferating cells show some abnormal structural features, falling short of carcinoma in situ. AH is considered a high-risk lesion and is found in about 5–10% of benign breast biopsies. It includes atypical ductal hyperplasia, ADH, where abnormal cells proliferate within the ducts, and atypical lobular hyperplasia, ALH, where abnormal cells proliferate within the lobular units.
Okay, so ADH and ALH are the ones to really pay attention to. They are considered markers of an increased bilateral breast cancer risk, maybe 4 or 5 times the baseline risk, or even higher depending on other factors. And importantly, the younger a woman is when she receives a diagnosis of atypical hyperplasia, the higher her cumulative future breast cancer risk seems to be. It signals an underlying predisposition or susceptibility in the breast tissue.
It's exactly. Evaluation of any breast symptom or finding involves a multimodal approach: clinical breast exam, mammography, ultrasound, sometimes MRI, and often a biopsy, needle, or surgical for definitive diagnosis. Interpreting mammograms can be challenging, especially in women with dense breasts, meaning more glandular and fibrous tissue relative to fat, as shown in figure 35.29. Dense tissue appears white on a mammogram, just like tumors can, potentially masking them. Breast density itself is also an independent risk factor for cancer. Historically, atypical lesions found on needle biopsy were almost always surgically excised to rule out adjacent cancer. However, newer data suggests that for some specific types of atypia found on core needle biopsy, careful observation might be an option for some women, though this is still evolving.
And this leads us directly to the ongoing mammography controversy. While screening mammography was introduced with the hope of greatly reducing breast cancer mortality, large studies have shown its benefits are less dramatic than initially hoped, particularly for mortality reduction. And there are definite harms, including false positives, leading to anxiety, further testing, unnecessary biopsies, and perhaps most significantly, the issue of overdiagnosis. Overdiagnosis means detecting cancers, particularly slow-growing or indolent ones, that would never have caused symptoms or harmed the woman during her natural lifetime if left undetected and untreated. A prime example is ductal carcinoma in situ, DCIS. This is a pre-invasive lesion, stage 0 cancer, meaning the abnormal cells are confined to the ducts and haven't invaded surrounding tissue. Figure 25.34 shows this. Widespread mammography led to a huge increase, almost an epidemic, of DCIS diagnoses. However, long-term studies show that removing DCIS hasn't significantly reduced the incidence of invasive breast cancer or overall breast cancer mortality. The understanding is emerging that breast cancer exists on a spectrum, from highly aggressive to very indolent, and screening preferentially finds many of these indolent or slow-growing lesions. Despite this, DCIS is still almost always treated aggressively, often like early-stage invasive cancer with surgery, often radiation, sometimes hormone therapy, even though many women diagnosed with DCIS have similar long-term survival rates to women in the general population without breast cancer. This highlights a really complex ethical and medical dilemma about the balance of benefits and harms in breast cancer screening and the subsequent treatment of screen-detected lesions like DCIS. Okay, now we come to breast cancer itself, which is, as the text emphasizes, a truly complex and heterogeneous disease. Let's talk about risk factors first. Reproductive factors play a role. Things like nulliparity, never having given birth, early menarche, starting periods young, late menopause, ending periods late, and maybe having short menstrual cycles all seem to increase risk slightly, likely related to cumulative lifetime estrogen exposure or more ovulatory cycles. Interestingly, pregnancy, especially having a first full-term pregnancy early in life, is generally protective long-term. However, there's a paradoxical transient increase in risk during pregnancy and for a few years postpartum called pregnancy-associated breast cancer, PABC. This might be related to hormonal surges or unique immune programs activated during breast tissue remodeling in involution after lactation. Hormonal factors are strongly implicated. We know excessive exposure to estradiol and perhaps insulin-like growth factor 1, IGF-1, increases risk. Most breast cancers, maybe 70–80%, are initially hormone dependent, meaning they express receptors for estrogen, ER+, and or progesterone, PR+. Estrogen acts as a growth factor, promoting their progression, and can also modulate immune function within the breast. A fascinating concept is that a lack of complete TDLU, terminal duct lobular unit, involution after menopause essentially, the persistence of glandular epithelium that should have regressed is emerging as a major risk factor. This lack of involution seems associated with higher prolactin and estradiol levels and lower progesterone levels. Environmental and lifestyle factors also play a significant role. Exposure to ionizing radiation is a known risk factor. Diet matters. Higher alcohol intake is consistently linked to increased risk. Being overweight or obese, especially after menopause, increases risk significantly, partly because adipose tissue, fat, becomes a major source of estrogen production via the aromatase enzyme. Obesity also promotes inflammation and alters levels of hormones like leptin and adiponectin, which can influence cell growth. A sedentary lifestyle increases risk, possibly through effects on insulin resistance, inflammation, and immune function. Even things like shift work involving night shifts might increase risk by disrupting circadian rhythms and melatonin production, potentially affecting IGF-1 signaling. The relationship with oral contraceptives is complex. Combined estrogen-progestogen pills seem to slightly increase the risk for breast, cervix, and liver cancers, but actually protect against ovarian and endometrial cancers. And as we mentioned, mammographic breast density, MBD, figure 35.29, is a significant independent risk factor, reflecting the amount of glandular and fibrous tissue.
Right. From a pathophysiology perspective, most breast cancers are adenocarcinomas, arising from the epithelial cells lining the ducts or lobules, often starting as carcinoma in situ, CIS. What's absolutely crucial to understand is the profound heterogeneity of breast cancer. It is not a single disease. It encompasses a wide range of diseases with diverse molecular profiles, biological behaviors, phenotypes, and pathologic appearances. Tumors are heterogeneous even within a single patient due to ongoing genetic and epigenetic changes and critical influences from the surrounding microenvironment.
hmm And this brings us to the absolutely vital role of the tumor microenvironment. Cancer is truly a tissue-based disease, not just a problem of rogue cells acting alone. The stroma, or the surrounding non-cancerous tissue, visualized in Figure 35.3, plays a critical active role through constant reciprocal interactions between the epithelial cancer cells and the stromal cells. This reactive stroma involves inflammatory cells, specialized fibroblasts called cancer-associated fibroblasts, CAFs, adipocytes, fat cells, immune cells, blood vessels, and the extracellular matrix, all of which can be co-opted by the cancer cells to actively promote tumor growth, invasion, angiogenesis, new blood vessel formation, and metastasis. Understanding and targeting this complex interplay is a major focus of current cancer research.
Exactly. To better understand this heterogeneity and guide treatment, gene expression profiling is increasingly used. This classifies tumors into intrinsic molecular subtypes based on their gene activity patterns, for example, luminal A, luminal B, HER2 enriched, basal-like triple negative. These subtypes have different prognoses and respond differently to therapies, allowing for more personalized treatment and surveillance strategies, moving away from a one-size-fits-all approach based just on histology. We mentioned ductal carcinoma in situ, DCIS, earlier, figure 35.34. These are proliferative lesions limited to the ducts or lobules without invasion through the basement membrane into the surrounding stroma. It accounts for the vast majority, and 84% of in situ breast disease diagnosed today, largely due to mammography screening. Changing perspectives on DCIS. As we discussed, widespread mammography led to an epidemic of DCIS diagnoses. However, long-term studies show that removing DCIS hasn't significantly reduced invasive cancer incidence or mortality as much as hoped.
The understanding is emerging that DCIS itself represents a spectrum of conditions, some of which might progress to invasive cancer if left alone, while others might remain stable or even regress. Screening preferentially finds many indolent or non-progressive lesions. Yet DCIS is still almost always treated like early-stage invasive cancer, surgery, radiation, sometimes endocrine therapy, despite women with DCIS having similar long-term overall survival rates to women in the general population. This significant overtreatment concern is leading to research into better ways to risk stratify DCIS and potentially manage low-risk cases more conservatively, perhaps with active surveillance. When breast cancer does become invasive and metastasizes, it often spreads first to lymphatics, especially axillary nodes, but can also travel through the bloodstream to the opposite breast, abdomen, lungs, bones, liver, brain, and other organs. This process involves complex events like further epigenetic alterations, crucial interactions between cancer cells and the stromal microenvironment, a process called epithelial to mesenchymal transition, EMT, that allows cells to become more mobile, potential periods of tumor dormancy, and even vascular mimicry, where tumor cells form vessel-like structures themselves.
Clinically, the first sign of invasive breast cancer is usually a small, painless lump or thickening. Other potential signs include palpable lymph nodes in the armpit, axilla, dimpling of the skin, nipple or skin retraction, nipple discharge, especially if bloody, ulcerations of the skin, localized redness or warmth, inflammatory breast cancer, or bone pain if metastasis has occurred.
Evaluation involves that careful clinical breast exam, mammography, ultrasound, sometimes thermography or MRI, and ultimately a biopsy for definitive diagnosis. Once cancer is confirmed, hormone receptor assays, ERPR, and HER2 testing are standard to guide therapy. Gene expression profiling may be used for further risk stratification and treatment decisions, especially for ER-positive HER2-negative cancers. Treatment depends heavily on the tumor's stage, subtype, and the patient's overall health and preferences. It typically involves a combination of surgery, lumpectomy or mastectomy, lymph node evaluation, radiation therapy, chemotherapy, hormone endocrine therapy for hormone-sensitive tumors, and targeted therapy like anti-HER2 drugs for HER2-positive cancers.
All right, let's transition now into part 3, focusing on alterations of the male reproductive system based on Chapter 36. Just as with females, males can experience a range of disruptions to their reproductive health, impacting everything from puberty to fertility and overall well-being. We'll start again with abnormalities of sexual maturation for males. Delayed puberty is defined as secondary sex characteristics developing after 14 to 14.5 years. The first noticeable sign typically being testicular enlargement. In about 95% of cases, it's simply a normal physiological delay, meaning the HPG axis is intact but just progressing slowly, often with a family history. It just takes a bit longer for things to get going. The other 5% are caused by a disruption of the HPG axis or systemic disease, such as a genetic condition like Klinefelter syndrome, where males have an extra X chromosome, gonadal failure, CNS tumors affecting the pituitary or hypothalamus, severe weight loss, or hypothyroidism.
And on the other hand, precocious puberty refers to the early onset of puberty in boys before age 9. There are primary forms. Complete precocious puberty involves premature but otherwise appropriate development for the child's sex, with the HPG axis functioning normally but just kicking in too early. Some cases can be idiopathic, but about 10% might be linked to lethal CNS tumors, emphasizing the importance of investigating the cause. Partial precocious puberty involves only partial development of secondary characteristics, like premature adrenarche, the growth of axillary and pubic hair between 5 and 8 years of age. This can sometimes progress to complete puberty. And mixed precocious puberty involves the development of some characteristics of the opposite sex, like feminization perhaps from an estrogen-producing tumor. Similar to girls, the main concern with complete precocious puberty in boys is that the early hormonal surge can lead to premature fusion of the growth plates and bones, ultimately affecting adult height. Treatment focuses on identifying and addressing the underlying cause if possible, or administering hormones to pause puberty.
Now, let's talk about disorders of the urethra and penis, which can present with various structural and functional issues. Urethritis is inflammation of the urethra, often caused by sexually transmitted infections like gonorrhea or chlamydia, but sometimes non-infectious. It typically causes dysuria, painful urination, frequency, urgency, maybe some tingling or itching, and sometimes a urethral discharge.
A consequence of untreated or severe urethritis, or sometimes trauma, like from catheterization or surgery, can be a urethral stricture. This is basically scarring that narrows the urethra. Symptoms are those of bladder outlet obstruction, a diminished force and caliber of the urinary stream, urinary frequency and hesitancy, maybe a double stream or spraying, and post-void dribbling. Treatment involves surgical procedures to widen the narrowed area, like dilation, urethrotomy, cutting the stricture, or sometimes more complex open reconstructive techniques.
Okay, 2 critical disorders related to the foreskin or prepuce in uncircumcised males are phimosis and paraphimosis. Figure Sum 6.1 illustrates these. Phimosis is when the foreskin cannot be retracted back over the glans penis. While this is normal in infants, in older children or adults, it's typically caused by poor hygiene leading to chronic infection and scarring. Complications can include balanitis, inflammation of the glands, posthitis, inflammation of the foreskin, urinary obstruction, and importantly, it increases the risk of developing penile carcinoma later in life. Paraphimosis is the opposite situation. The foreskin has been retracted, but then it cannot be moved forward, reduced back over the glands. It gets stuck behind the head of the penis.
Right, and this is dangerous because the tight retracted foreskin can form a constricting band, like a tourniquet, around the penis just behind the glands. This severely impedes venous blood flow and lymphatic drainage, leading to swelling, pain, and potentially arterial compromise and tissue death, necrosis of the glands. Here's the key takeaway. Both severe obstructive phimosis and any case of paraphimosis are considered urologic emergencies that require prompt medical intervention to prevent serious complications. Treatment for phimosis after any infection is controlled is often circumcision. Paraphimosis requires immediate manual reduction, squeezing the swelling out and pulling the foreskin forward, sometimes needing procedural sedation or even a small surgical incision, dorsal slit, to release the constriction.
Okay, another condition is Peyronie disease, sometimes called bent nail syndrome. Figure 36.2 shows the effect. This involves the development of fibrous plaques, or hard scar tissue, within the connective tissue sheath, tunica albuginea, surrounding the corpora cavernosa, the erectile tissues of the penis. This fibrosis causes the penis to curve or bend during erection, often making intercourse difficult or painful.
Yeah, the exact cause is unknown, but it's thought to be related to minor trauma during intercourse, leading to inflammation and abnormal wound healing. It's associated with conditions like Dupuytren contracture in the hand, diabetes, keloid formation, and possibly the use of beta blocker medications. There's no single definitive treatment, but some cases resolve spontaneously. Options include oral medications, injections directly into the plaque like collagenase, traction devices, and surgery for significant deformity interfering with function, though surgery carries risks like shortening or nerve damage.
Right. A very serious condition we must mention is priapism. This is a prolonged, usually painful erection that persists beyond or is unrelated to sexual stimulation. Figure 36.3 depicts this. It's typically caused by impaired blood outflow from the erectile tissues. This is considered a urologic emergency because the trapped, deoxygenated blood can damage the erectile tissue, leading to permanent erectile dysfunction impotence, if not corrected within hours, usually 4 to 6 hours.
Exactly. About 60% of cases are idiopathic, unknown cause, but it can be associated with spinal cord trauma, sickle cell disease where abnormal red blood cells block outflow, leukemia, pelvic tumors or infections, or penile trauma. Certain medications can also trigger it. Treatment requires immediate intervention to drain the trapped blood and restore normal circulation. This might involve iced saline enemas, specific medications like phenylephrine injection, spinal anesthesia, needle aspiration of blood from the corpora cavernosa, or creating surgical shunts to divert blood flow. Time is critical.
We should also briefly mention balanitis, which is inflammation of the glans penis, shown in figure 36.4. It's often associated with posthitis, which is inflammation of the foreskin. It's commonly linked to phimosis, poor hygiene in uncircumcised males, skin disorders or infections, particularly Candida albicans, yeast.
And finally, under penile disorders, we have tumors of the penis. Benign tumors like condyloma acuminatum, genital warts, are caused by low-risk HPV types, usually 6 and 11. Sometimes giant condylomata can occur in older men. Penile cancer, however, is malignant. Although relatively rare in the U.S., it's more common in parts of Africa and South America, typically affecting men between 40 and 70 years old.
Key risk factors include infection with high-risk HPV types, implicated in up to 60% of invasive cases, AIDS, smoking, and possibly treatment for psoriasis involving UV light. As we mentioned, circumcision at birth appears to decrease the risk significantly, and it's also more common in men with phimosis and poor hygiene, suggesting a role for chronic irritation and inflammation. Pathophysiologically, about 95% are squamous cell carcinomas. They are often preceded by premalignant lesions like leukoplakia, white patches, erythroplasia of Queyrat, red patches on the glands, or Bowen disease, Buschke-Lowenstein patches. Clinically, it typically starts as a small, flat, ulcerative or papillary wart-like lesion, often on the glands or foreskin. If untreated, it grows to envelop the penile shaft. Extensive lesions are linked to metastases, usually first to the inguinal groin, lymph nodes, then potentially iliac nodes and beyond. Staging, outlined in box 36.3, is based on primary tumor size, T, regional lymph node involvement, N, and distant metastasis, M. Diagnosis requires a biopsy. The good news is that penile cancer is highly curable if diagnosed and treated early, usually with surgery, ranging from local excision to partial or total penectomy, and sometimes radiation or chemotherapy. Okay, let's move down to disorders affecting the scrotum, testis, and epididymis. Men might seek treatment for scrotal masses or swelling, which can range from benign conditions to serious emergencies or cancer. Careful evaluation is always needed. One common scrotal abnormality, often identified in infertile men, is a varicocele. This is an abnormal dilation of the testicular vein and the pampiniform plexus, the network of veins draining the testis, classically described as feeling like a bag of worms on palpation. Figure 36.5 shows this dilation. It most commonly occurs on the left side due to the anatomical difference in how the left testicular vein drains into the renal vein at a right angle, leading to higher pressure. While it can sometimes cause a dull ache or feeling of heaviness, its most significant impact is that it can impair sperm production and quality, possibly due to increased scrotal temperature or reflux of adrenal metabolites. Surgical repair, ligation or embolization of the dilated veins, is an option if it's causing significant symptoms or contributing to infertility.
Next, a hydrocele. This is a collection of serous fluid between the two layers of the tunica vaginalis, the membrane surrounding the testes. Figure 36.6 illustrates this fluid accumulation. It's the most common cause of scrotal swelling. It can be congenital, common in newborns, due to a persistent connection with the abdominal cavity, processus vaginalis, which usually closes spontaneously. In adults, it can develop secondary to infection, like epididymitis or orchitis, trauma, testicular torsion, or tumors, or following surgery, like varicocele repair. While usually painless, large hydroceles can be uncomfortable. It's crucial to evaluate for an underlying testicular cancer, especially in older men presenting with a new hydrocele.
Okay. And a spermatocele, also known as an epididymal cyst, shown in figure 36.7. This is a benign cystic accumulation of sperm and fluid that arises from the epididymis or rete testis, located usually superior and posterior to the testes, feeling separate from it. They are generally asymptomatic and don't require treatment unless large and bothersome.
Now, a really important developmental issue: cryptorchidism and ectopi. Cryptorchidism literally means hidden testes and describes a group of abnormalities where one or both tests fail to descend completely from the abdomen into the scrotum during fetal development. The testes might remain in the abdomen, get stuck in the inguinal canal, or stop just outside the external ring at the puboscrotal junction. It's one of the most common congenital anomalies in males, affecting about 3–4% of full-term male infants, higher in premature infants. Unilateral is more common than bilateral. Ectopic testes is when a testis has strayed from the normal path of descent and ends up in an abnormal location, like the perineum or thigh. The causes are complex and not fully understood, but possibilities include abnormalities of the gubernaculum, the structure guiding descent, a congenital defect making the testes insensitive to gonadotropins, lack of maternal gonadotropins, or mechanical factors like a short spermatic cord or narrowed inguinal canal. We distinguish this from a retractile testis, physiologic cryptorchidism, where a normally descended testis is pulled back up into the groin by an overactive chromastric reflex, which is usually self-limiting. Here's the crucial insight regarding cryptorchidism. The serious complications of an uncorrected, undescended testes include impaired fertility. Spermatogenesis is impaired by the higher abdominal temperature, especially if both testes are affected, and a significantly increased risk of developing testicular cancer later in life, maybe 35 to 50 times greater than for the general male population. Importantly, this increased cancer risk applies even to the contralateral, normally descended testes, suggesting a more widespread developmental abnormality or genetic predisposition. Because of histological changes, damage to germ cells that begin relatively early due to the higher temperature, surgical correction called orchiopexy, bringing the testes down and fixing it in the scrotum, is recommended relatively early, usually around 1 year of age. If found in an older adolescent or adult, removal of the undescended testes, orchiectomy, might be considered due to the high cancer risk and poor sperm production potential.
Okay, now for a true and very urgent emergency. Torsion of the testis. This is when the testes rotates on its vascular pedicle, the spermatic cord, twisting the blood vessels within the cord. This immediately interrupts arterial blood supply to the testis and venous drainage from the testis, leading to ischemia and infarction, tissue death, if not corrected rapidly. This is a surgical emergency that requires correction within 6 hours of symptom onset to have the best chance of salvaging the testis. Any sudden onset of severe testicular pain, often accompanied by swelling and sometimes nausea vomiting, warrants immediate medical attention and evaluation, usually with Doppler ultrasound to check blood flow.
Absolutely critical to act fast. Another condition is orchitis, which is acute inflammation or infection of the testes themselves. It's often a complication of a systemic infection, most classically mumps in unvaccinated individuals, but can also result from extension of bacterial epididymitis or other infections. It causes testicular pain, swelling, and tenderness. Complications can include hydrocele formation, testicular abscess or later, testicular atrophy, and impaired fertility.
Finally, we must discuss testicular cancer. Although relatively uncommon overall, about 1% of male cancers, it is the most common cancer in males between 15 and 35 years old, a critical age group. Pathophysiologically, about 90% of testicular cancers are germ cell tumors, GCTs, meaning they arise from the primordial germ cells, the cells destined to produce sperm. These are further classified into seminomas and non-seminomas, which include embryonal carcinomas, teratomas, yolk sac tumors, and choriocarcinomas, which have different treatment approaches and prognosis.
Right. While the exact cause is unknown, genetic predisposition is suggested by higher incidence in brothers or identical twins. A history of cryptorchidism is a major risk factor, as we discussed. Other risk factors include abnormal testicular development, like Klinefelter syndrome, and possibly HIV/AIDS infection or prior testicular cancer in the other testes. Clinically, the first manifestation is typically a painless testicular enlargement or lump, sometimes discovered incidentally. There might be a sensation of heaviness or a dull ache in the scrotum or lower abdomen. Acute pain is less common but can occur due to hemorrhage or necrosis within the tumor. Occasionally, symptoms related to metastases, like back pain from retroperitoneal lymph nodes, cough dyspnea from lung mets, or neck swelling, might be the initial signs. Gynecomastia can occur if the tumor produces HCG. Diagnosis is often delayed because the initial lump is painless. Careful physical exam, palpation, is key, feeling for a firm, non-tender mass within the testes. Scrotal ultrasonography is highly sensitive for detecting testicular masses. Blood tests for tumor markers, alpha-fetoprotein, AFP, beta-HCG, and LDH are crucial for diagnosis, staging, and monitoring response to treatment, though seminomas typically don't produce AFP. CT scans are used for staging to look for metastasis. Testicular self-examination, TSE, starting after puberty, is recommended by many doctors to promote early detection. And here's that crucial point again. Testicular biopsy is generally not recommended for a suspected primary tumor due to the risk of tumor seeding or dissemination through the scrotal skin. Instead, the standard approach, if cancer is suspected based on exam, ultrasound, and markers, is radical inguinal orchiectomy, surgical removal of the entire testes and spermatic cord through an incision in the groin. Treatment depends on the type,
seminoma versus non-seminoma, and stage, but usually involves surgery, orchiectomy, sometimes followed by radiation, especially for seminomas, or chemotherapy, especially for non-seminomas or metastatic disease. Sperm banking should always be discussed before treatment due to the high risk of infertility from treatment. The good news is that with modern therapy, the overall prognosis for testicular cancer is generally excellent, with cure rates exceeding 95% even for metastatic disease in many cases, making early detection and appropriate treatment vital. Okay, let's turn now to the prostate gland, a small gland surrounding the urethra at the base of the bladder in males, which can certainly cause a variety of problems, especially as men age. We'll start with benign prostatic hyperplasia, BPH, sometimes called benign prostatic hypertrophy, which is a non-cancerous enlargement of the prostate gland. This is incredibly common, affecting over half of men by age 60 and nearly 90% by age 80. It's almost a normal part of aging for many men. The causes of BPH are complex and likely multifactorial, but current theories point to aging itself, the changing levels and ratios of endocrine factors, particularly androgens like dihydrotestosterone, DHT, and estrogens, the role of chronic inflammation within the prostate, and various autocomparacrine growth factors. Prostate stronal cells seem to play a key role in the inflammatory and growth processes. Pathophysiologically, BPH typically begins in the periurethral glands, which are in the inner layers, transition zone, of the prostate surrounding the urethra. The prostate enlarges as nodules form, due to both hyperplasia, increased cell number, and hypertrophy, increased cell size. As these nodules grow, they compress the prostatic urethra, as shown nicely in figure 36.2, causing bladder outflow obstruction. Clinically, this leads to that well-known spectrum of lower urinary tract symptoms, LUTS. These can be categorized as obstructive symptoms: hesitancy in starting urination, decreased force and caliber of the urinary stream, intermittency, straining, post-void dribbling, sensation of incomplete emptying, and irritative symptoms: urinary frequency, urgency, nocturia, waking up at night to urinate. As the obstruction progresses and the bladder has to work harder to push urine out, it can lead to long-term urine retention, bladder muscle dysfunction, overflow incontinence, hematuria, blood and urine, recurrent urinary tract infections, bladder calculi stones, and in severe untreated cases, back pressure on the kidneys causing hydroureter, hydronephrosis, and even renal insufficiency. Diagnosis involves a thorough medical history, using symptom scores like the AUA Symptom Index, a physical exam including a digital rectal exam, DRE, to feel the size and consistency of the prostate, urinalysis to rule out infection, and usually a PSA, prostate-specific antigen blood test. PSA can be elevated in BPH, prostatitis, and prostate cancer, so it's not specific for cancer, but helps in assessment. Other tests might include transrectal ultrasound, TRUS, to estimate prostate volume and check for residual urine after voiding, uroflowmetry to measure urine flow rate, or urodynamic studies, cystometry, to assess bladder function. Treatment options range from watchful waiting for mild symptoms to medications like alpha-1 adrenergic blocker, tamsulosin, which relax the smooth muscle in the prostate and bladder neck to improve flow, or 5-alpha reductase inhibitors, e.g. finasteride, which block the conversion of testosterone to DHT, thereby shrinking the prostate over time. Combination therapy is often used. Minimally invasive treatments, using laser, radiofrequency, steam, etc., are also available. For severe symptoms or complications, surgical options like TURP, transurethral resection of the prostate, where obstructing tissue is removed endoscopically, remain a mainstay.
Right. Now let's discuss prostatitis, which is simply inflammation of the prostate. The NIH has developed a useful classification system outlined in box 36.4 because it's not just one condition. Category I is acute bacterial prostatitis, ABP. This is an acute infection of the prostate, often presenting quite dramatically with systemic signs like malaise, low back and perineal pain, high fever, and chills, along with urinary symptoms like dysuria, frequency, urgency, and sometimes urinary retention. On exam, the prostate is typically enlarged, very tender, and feels boggy. This usually occurs in younger men, 30-30, but can also happen in older men with BPH. It can be considered a medical emergency if acute urinary obstruction occurs. Treatment requires prompt antibiotics, often IV initially for severe cases, analgesics, bed rest, and hydration. Importantly, placing a Foley catheter through the urethra is usually contraindicated during the acute infection due to pain and risk of spreading infection. A temporary suprapubic catheter might be needed for drainage if retention occurs. Category 2 is chronic bacterial prostatitis, CBP. This is characterized by recurrent urinary tract infection, UTI symptoms, and persistent pathogenic bacteria found in urine or prostatic fluid cultures obtained after prostatic massage. It's actually the most common cause of recurrent UTIs in men. Symptoms are often similar to an acute bladder infection, frequency, urgency, dysuria, but usually milder and may wax and wane. The prostate itself may feel slightly enlarged or boggy, or sometimes fibrotic and irregular from repeated infections. Diagnosis requires careful culture techniques. Treatment can be difficult because antibiotics penetrate the prostate poorly, and bacteria can sometimes hide within prostatic calculi stones. Longer courses of antibiotics, 4 to 12 weeks, are often needed, and sometimes surgery is required if stones are harboring infection. Category 3 is chronic pelvic pain syndrome, CPC-PPS. This is the most common type of prostatitis, but also the least understood. Here, men have symptoms of prostatitis, pelvic pain, urinary symptoms, painful ejaculation, but no pathogenic bacteria are consistently localized to the prostate. It's further divided into theria, inflammatory, with white blood cells found in prostatic secretions, and therit, non-inflammatory. Symptoms are often milder than acute prostatitis, but persistent and bothersome, including pain or ache in the suprapubic area, scrotum, penis, or groin, painful ejaculation, and urinary frequency urgency. The prostate usually feels normal on palpation. The cause is often unclear, with theories including reflux of sterile urine into prostatic ducts, autoimmune processes, or neuromuscular dysfunction. Treatment is often aimed at symptom management.
And finally, category 4 is asymptomatic inflammatory prostatitis. Here, evidence of inflammation, bacteria or white blood cells, is found incidentally in prostate tissue or fluid. For example, during evaluation for infertility or elevated PSA, but the patient has no symptoms. Generally, no treatment is needed. The microorganisms most often implicated in bacterial prostatitis, categories 3 and 2, are typically gram-negative gut bacteria like E. coli, Enterobacter, and Pseudomonas aeruginosa, often descending from the urethra. Helicobacter pylori has also been implicated in some studies. Diagnosis involves careful history, the digital rectal exam, analysis and culture of urine before and after prostatic massage, microscopic examination of prostatic fluid, and sometimes urothroscopy or urodynamic studies to rule out other causes.
Okay, let's move into male sexual dysfunction. A major issue here is erectile dysfunction, ED, which is the inability to achieve or maintain an erection sufficient for satisfactory sexual intercourse. It's very common, increasing with age, and can have significant impacts on quality of life and relationships. Causes can be broadly categorized as organic or psychogenic, although often there's an overlap. Organic causes include vascular disease like atherosclerosis affecting blood flow to the penis, endocrine disorders like diabetes causing neuropathy and vascular issues or low testosterone, neurologic diseases like spinal cord injury, MS, Parkinson's, trauma, pelvic surgery or injury, and side effects from many common medications, antihypertensives, antidepressants, etc. Psychosocial causes include performance anxiety, depression, stress, relationship problems, or lack of sexual arousal. For treatment, the landscape changed dramatically with the introduction of oral phosphodiesterase type 5 inhibitors, PDE5I, like sildenafil, Viagra, vardenafil, Levitra, tadalafil Cialis, and avanafil Stendra. These drugs work by enhancing the effect of nitric oxide, a chemical released during arousal that relaxes smooth muscles in the penis, allowing increased blood flow needed for an erection. They've been truly revolutionary for many men.
They have been. However, a word of caution about PDE5 inhibitors. They are generally safe, but do have potential side effects and contraindications. They can cause headache, flushing, indigestion, and nasal congestion. More seriously, they can cause a significant drop in blood pressure, especially if taken with nitrates, used for heart conditions. So that combination is absolutely contraindicated. There can also be specific side effects like visual changes, bluish tinge with sildenafil, potential QT prolongation with vardenafil, and back pain or muscle aches with tadalafil. Careful screening and discussion with a doctor are essential. Other non-surgical approaches involve identifying and correcting underlying disorders, like managing diabetes, treating low testosterone if present, changing medications if possible, using vacuum erection devices, intraurethral suppositories, MESE, or intracavernosal injections, injecting vasodilators directly into the penis. Lifestyle changes like quitting smoking, weight loss, and exercise can also help. Surgical options are generally reserved for cases where other treatments fail or are unsuitable. These include implanting penile prostheses, inflatable or malleable rods, or rarely performing penile revascularization surgery for specific types of vascular blockage in young men. Next, let's consider impairment of sperm production and quality, a key factor in male infertility. Remember, spermatogenesis requires adequate FSH and LH from the pituitary and sufficient testosterone T production by the testes. Causes of impaired sperm production can be hormonal issues, inadequate gonadotropin secretion, like in hypogonadotropic hypogonadism, or conditions affecting hormone balance like hypothyroidism, hypergenocortisolism, Cushing's, or hyperprolactinemia. Low testosterone levels directly impair spermatogenesis, testicular response defects. The testes might not respond properly to gonadotropins due to genetic defects or damage. Temperature issues. As we discussed, testes need to be cooler than core body temperature. Conditions like febrile illness, cryptorchidism, or prolonged exposure to high temperatures like in hot tubs, saunas, or maybe even from tight clothing or laptops on the lap can kill sperm or impair their function. Seminal tract issues. Problems with the epididymis, vas deferens, prostate or seminal vesicles can affect sperm maturation, transport, or the quality of seminal fluid, e.g. excessive viscosity. Anti-sperm antibodies. These can develop even after vasectomy reversal or testicular trauma in about 17% of infertile males. They can be cytotoxic, reducing sperm number, or sperm immobilizing, impairing motility. Sexual dysfunction itself can disrupt ejaculation, preventing sperm delivery. Genetic factors like Y chromosome microdeletions or Klinefelter syndrome can directly cause severe defects in sperm production. Environmental toxins or certain medications can also be gonadotoxic. Diagnosis starts with a detailed semen analysis, looking at volume, sperm concentration, count, motility, percentage moving, and how well. Morphology, shape, vitality, and sometimes more advanced tests like sperm DNA fragmentation analysis. Multiple analyses are usually needed. Hormonal assays, FSH, LH, testosterone, prolactin, are also essential. Treatment involves correcting underlying disorders if possible, e.g., treating infections, hormonal imbalances, avoiding gonadotoxins or excessive heat, surgical correction of obstructions like varicocele repair or vasectomy reversal, using assisted reproductive technologies like IUI or IVFI-CSI where sperm are directly injected into eggs, or using donor sperm. And again, preventing STIs is key to avoiding infections that can cause epididymitis, orchitis, or ductal obstruction.
Okay, let's briefly touch on disorders of the male breast, specifically gynecomastia. This is the overdevelopment or enlargement of breast tissue in males, not just fat deposition, pseudogynecomastia. It accounts for about 85% of all male breast masses and is actually quite common. It can be unilateral, typically affecting the left breast more often, or bilateral. Its incidence shows peaks during adolescence, pubertal gynecomastia, and in men over 50 years, senescent gynecomastia. The underlying cause is almost always related to hormonal alterations, specifically an imbalance of the estrogen to testosterone ratio. Either there's too much estrogen effect relative to androgen effect, or not enough androgen effect relative to estrogen. This imbalance can happen in several ways. High estrogen, normal testosterone. This can be drug-induced, for example, from estrogen therapy used for prostate cancer, digitalis, cimetidine, spironolactone, some recreational drugs, or tumor-induced if certain tumors in the testes, adrenals, liver, or pituitary adenomas, even some lung cancers, produce estrogen or its precursors. Low testosterone, normal estrogen. This occurs in conditions of primary or secondary hypogonadism, testicular failure or pituitary hypothalamic issues, or genetic conditions like Klinefelter syndrome. Altered tissue responsiveness. Sometimes the breast tissue itself might become more sensitive to normal estrogen levels or less sensitive to normal androgen levels. This might explain some idiopathic cases.
Gynecomastia can also be associated with various systemic disorders that affect hormone metabolism or balance, such as liver cirrhosis, which impairs estrogen breakdown, chronic hepatitis, chronic renal failure, COPD, hyperthyroidism, tuberculosis, or chronic malnutrition, especially during refeeding, which can temporarily alter the ET ratio. Clinically, it presents as a firm, sometimes tender, palpable mass of glandular tissue, 2 centimeters in diameter, located directly beneath the areola. If it's primarily hormone-induced, it's often bilateral. If drug-induced, it might be unilateral. Treatment involves identifying and treating the underlying cause if possible, e.g., stopping an offending drug treating a thyroid disorder. Pubertal and senescent gynecomastia often regress spontaneously within 6 to 24 months. If it's persistent, cosmetically bothersome, or painful, medical therapy, like tamoxifen, or surgical removal of the glandular tissue might be considered. Importantly, any firm, eccentric, or suspicious male breast mass requires evaluation to rule out the rare possibility of male breast cancer. Self-examination and re-examination if it persists are advised. Finally, we need to circle back and emphasize sexually transmitted infections, STIs, because they are truly a major public health concern, and, as we've seen throughout this discussion, they are responsible for causing many of the reproductive system alterations in both men and women. They can be caused by a whole host of pathogens. Bacterial, like chlamydia, gonorrhea, syphilis; viral, like HPV, HSV, HIV, hepatitis B, C; protozoan, trichomonas; parasitic, bibiclice, scabies; or fungal, candida, though usually considered an opportunistic infection. Table 36.1 in the text gives a good overview. The impact is just profound and far-reaching. We talked about chlamydia and gonorrhea being major causes of pelvic inflammatory disease, PID, in women, which is a leading cause of preventable infertility and ectopic pregnancies. We discussed HPV being strongly linked to cervical, vaginal, and vulvar cancers in women, as well as penile cancer and condyloma acuminatum, genital warts in men, not to mention oropharyngeal cancers linked to oral HPV infection. Syphilis, if untreated, can cause devastating systemic complications. HIV obviously compromises the immune system, making individuals susceptible to other infections and cancers. Hepatitis B and C can lead to chronic liver disease and liver cancer. Herpes causes recurrent painful lesions. Here's the critical takeaway. STIs are a cross-cutting threat because they don't just cause acute infections. Their potential long-term health consequences in fertility, ectopic pregnancy, chronic pain, cancer, systemic illness, adverse pregnancy outcomes, and facilitating HIV transmission are enormous. This really raises an important question for all of us. Given our knowledge of transmission and consequences, why does the prevention and control of STIs remain such a persistent global health challenge?
It's a huge challenge. Prevention is absolutely crucial for reducing the incidence of so many of these reproductive disorders and their long-term health consequences. This means promoting comprehensive sexual health education, encouraging regular screening for STIs, especially in young and at-risk populations, ensuring access to prompt and effective treatment for individuals and their partners, promoting consistent and correct use of barrier methods like condoms, and utilizing effective vaccines where available, particularly the HPV vaccine. These strategies are key to mitigating this pervasive threat, not just for individual health and well-being, but truly for public health on a global scale. #outro. Wow, okay, that was quite a journey. From those incredibly early embryonic differentiations guided by just a single gene like SRY, to the intricate hormonal dance of puberty and the menstrual cycle, through the subtle but significant shifts of aging like menopause and andropause. And then exploring all the diverse ways these systems can face challenges, whether it's from hormonal imbalances in conditions like PCOS or gynecomastia, the mechanical loss of support leading to pelvic organ prolapse, or insidious infections like HPV and chlamydia causing infertility or serious cancers. We've really covered the incredible complexity and sometimes the vulnerability of both male and female reproductive systems.
Absolutely. And the key takeaway here, as we've seen again and again, weaving through chapters 34, 35, and 36, is the intricate interconnectedness of these systems, not just within themselves, but also their profound impact on overall health and quality of life. Understanding the pathophysiology, the why and how behind these conditions, the mechanisms of disease is not just an academic exercise. It's absolutely fundamental to effective clinical practice, to informed patient decision-making, and crucially, to disease prevention and health promotion. This deep dive, I hope, has really shown how every part influences the whole, and how a seemingly small detail, like a hormone imbalance or a single gene, can have such widespread effects.
It really has. So, as you, our listener, reflect on this deep dive, maybe consider the delicate balance required for these systems to function optimally throughout the entire lifespan. What steps can you take or perhaps advocate for in your community or practice to support reproductive health, from promoting comprehensive education for young people to ensuring access to preventative services like screening and vaccination, and advocating for timely, accessible, and evidence-based care for those experiencing problems?
Well said. Thank you all for joining us on this deep dive. We sincerely hope this session from the Last Minute Lecture team has provided you with valuable insights and a clearer, more integrated understanding of reproductive pathophysiology based on this unit.
Until next time, keep diving deep into knowledge.